Hi, friends. Today, let's discuss a question that comes up almost every week in diabetes and obesity clinics. Tirzepatide or semaglutide, which is better? Let's start with weight loss. Across randomized trials, meta-analyses, and real-world data, tirzepatide consistently shows greater weight reduction than semaglutide, with a clear dose-response effect. A large 2025 systematic review and meta-analysis, including over 140,000 patients, found that tirzepatide achieved an additional 4 to 4.5 percentage points greater weight loss compared with semaglutide. At higher doses, particularly 10 to 15 milligrams, the difference increased to about 6 to 7 percentage points. Now let's look at direct head-to-head data. In the SURMOUNT-5 trial, which directly compared the two drugs in people with obesity without diabetes, tirzepatide produced approximately 20% weight loss, compared with around 14% with semaglutide at 72 weeks. This trial also showed greater waist circumference reduction with tirzepatide. Importantly, real-world cohort studies in people with overweight and obesity treated with diabetes-labeled doses show the same pattern. Larger percentage weight loss with tirzepatide, with similar gastrointestinal adverse event rates compared with semaglutide. Now let's talk about glycemic control. In indirect comparisons of SURPASS and STEP-style trials, tirzepatide at doses of 10 to 15 milligrams lowers HbA1c by about 0.5 to 0.8% more than semaglutide at doses of 1 to 2 milligrams, when baseline characteristics are comparable. Regarding body composition, imaging-based analyses from the SURPASS and SURMOUNT programs suggest that tirzepatide leads to greater absolute fat mass loss, with some lean mass loss as expected. However, the proportion of lean mass is relatively preserved, and more detailed muscle quality data are still emerging. Now let's discuss safety and tolerability. Both drugs share class-typical GLP-1 adverse effects, including nausea, vomiting, and diarrhea. At higher tirzepatide doses, gastrointestinal symptoms are numerically more frequent, but are usually manageable with slow-dose escalation. Discontinuation due to adverse events is similar or slightly higher with tirzepatide, depending on dose and population. Now the most important part, cardiovascular outcomes. This is where semaglutide currently has more robust evidence. Semaglutide has multiple placebo-controlled cardiovascular outcome trials, demonstrating reduction in major adverse cardiovascular events in patients with type 2 diabetes. Tirzepatide has shown non-inferiority compared with dulaglutide, which itself has proven cardiovascular benefit. So at present, cardiovascular benefit evidence remains stronger and more established for semaglutide. How do guidelines position these drugs? The 2026 ADA Standards of Care and recent obesity pharmacotherapy guidelines list both semaglutide and tirzepatide as preferred high-efficacy injectable therapies. Tirzepatide is generally recognized as achieving the greatest mean weight loss among currently approved agents, with semaglutide close behind. So how should we choose between them in practice? If the primary goal is maximum weight loss and maximal HbA1c reduction, and cost or access is not a barrier, tirzepatide is usually the more potent option. If the patient has established atherosclerotic cardiovascular disease or very high cardiovascular risk, and you want proven cardiovascular outcome benefit, semaglutide remains the more evidence-secure choice. So the take-home message is simple. Tirzepatide wins on magnitude of metabolic effect. Semaglutide wins on cardiovascular outcome evidence.